Good evening to everybody. On behalf of IAP TNSC, I welcome respectable judges as well as chairperson and moderator. And I will start with the pediatrics prayer by our treasurer, Dr. Gopal Subramanian.
Good evening, one and all, respected seniors and my dear friends. We'll start today's program with the pediatrician's prayer. குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும், நோயின் துன்பத்திற்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்களின் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாதவற்றை காரணத்தின் ஏற்றுக்கொள்ளவும் போதுமான மெய்யர்களும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளும். நன்றி.
Thank you, Dr. Gopal. It's my duty to introduce our today's chairperson as well as moderator. And on behalf of IAP TNSC, I welcome our today's chairperson. First of all, I congrats Dr. Professor Dr. Ramachandra Mohan. She's currently is promoted as a director, Institute of Social Pediatrics, Stanley Medical College. Congrats, madam.
Congratulations from all of us.
Thank Congrats, ma'am. Congrats, ma'am.
Thank you. Thank you.
I'm really happy that my batchmate, I can tell proudly. Okay, thank you very much, madam. And next, I welcome today's moderator, Dr. P. Sendil Kumar, a senior assistant professor of neonatology at Coimbatore Medical College. I welcome Dr. Sendil Kumar. Sendil, can you hear me?
Yes, sir. Yes, sir.
Okay, now I welcome Dr. Chandra Kumar, HOD Department of Neonatology, Kanjigamagodi Trust Hospital, Chennai. I welcome Dr. Chandra Kumar.
Thank you, sir.
I welcome today's judges, Dr. Elilarsi Madam, Janani Shankar, PRC sir, and Dr. Srinivasan sir from Pondicherry. I welcome Stanley Medical College postgraduates, Dr. Karni Ramachandran, today's presenter, and Dr. Jayapratha and Dr. Nivedita from Stanley Medical College who are going to participate in the case discussion. And I say really happy that our program is doing very well. And I think I welcome Dr. PRC sir. He's content, thank you. And once again, on behalf of IAP TNSC, I welcome one and all. Now it is over to Dr. Ramachandra Mohan. So Ramachandra Mohan, madam, because of seniority, we put it as a chairperson, but he will be a chief moderator. Yeah, she can't escape. Madam, please. Yeah.
Thank you, Dr. Rajendran. I know you're doing excellent work putting all these PG clinics together, and the students learn a lot in these evening sessions. It's convenient for them because they finish work also and they're able to take part, and they're examined by people from different hospitals. And Chandra and Sendil was my student. I'm proud to say Chandra, I've known him for a long time. Both are excellent examiners. So Rajendran, I'm going to hand over the proceedings to them, and I will chip in once in a way. Okay, because they are my postgraduates, so I don't want to seem biased. So it's over to the presenters first.
Dr. Sendil Kumar, you have a few words. Dr. Sendil Kumar.
Yes, sir. Let them start the presentation, sir.
Can we see you, Sendil?
Madam, good evening, madam. Good evening, madam. Madam, sorry, madam. ஒரு சின்ன நெட்வொர்க் இஷ்யூ நான் ஒரு 2 மினிட்ஸ்ல சார்ட் அவுட் பண்ணிடுவேன். உடனே நான்
You can start listening to them அப்போ நம்ம
Chandra Kumar.
Yes, sir.
Good evening, sir. Good evening, everyone. Thanks for the opportunity. I think without any formality, we will start the presentation.
Dr. Harini, you can share your slide, please.
A very good evening to everyone. I'm Dr. Harini from Stanley Medical College, and I would like to present a preterm child for today's case discussion. The child in our discussion is baby of Devi, who is a 32-day second-born female child of non-consanguineous marriage, born at 26-week gestation on 22nd of October at 7:15 p.m. by spontaneous labor, and was admitted at birth in our NICU in view of respiratory distress and for preterm care. The informant is her mother, whose reliability is good, and she speaks in Tamil. Presenting illness, the child is currently remaining in admission for the sake of monitoring of weight gain and for laser correction of ROP of her right eye. She is currently taking adequate 2-hourly feeds via EBM, which is being given through Paladai as well as orogastric tube feeds, and she takes approximately 20 ml per feed with fortification. Vitamin and calcium supplementation is being given, and child is kept under kangaroo mother care for approximately 12 hours per day. She passes urine and stools adequately. Mother has noticed an improving activity and a good cry, and she does not have any specific complaints at present. Antenatal history. The mother conceived when she was 23 years of age, and she is 153 centimeters tall and weighs 40 kilos. Her BMI is 17, and she has been married for the past 2 years. Her obstetric code is para 2 live 2 because she has had one previous child who was also late preterm gestation, and the child is currently 1 year of age. Her LMP for the current pregnancy was 2nd of April and EDD 9th of January. Number of antenatal checkups were 11, and her blood group is B positive. First trimester history. Child was of a spontaneous conception. Mother had registered at Madhavaram UPHC. Pregnancy was confirmed by urine pregnancy test. Dating scan was done in the 3rd month of gestation, around 10 weeks of gestational age, and mother consumed vitamin supplements. There was no history of hyperemesis gravidarum, no history of fever with rash, painful lymphadenopathy or arthralgia. There was no history of pet animals at home, and no history of drug intake or radiation exposure. Second trimester, the mother consumed iron and folic acid and calcium supplementation taken from the second trimester until delivery, and she felt quickening at the 5th month. The first dose of tetanus toxoid was taken. Anomaly scan was done at the end of the 5th month and was reported to have an apparently normal fetus but low-lying placenta. She was informed that she was pale and she needed extra supplementation. There was no history of any other medical illness, acute or chronic ailments such as chronic lung or liver diseases, no history of any heart disease, no history of gestational diabetes, pregnancy-induced hypertension or hypothyroidism. There was no history of leaking per vaginum, but mother had spotting since 22nd week of gestation, on and off, for which she was given IV medication as well as oral drugs, and she was advised strict bed rest. She was hospitalized twice during the 6th month, and each hospitalization was for approximately 5 days and was regularly followed up in a maternity nursing home. Third trimester, the mother continued to perceive fetal movements until the start of the 7th month. There was no history of GDM, PIH, or any history suggestive of UTI. Weight gain during pregnancy was approximately 5 kilos. She was admitted once again at 25th week for bleeding per vaginum as well as leaking PV. And she received IV fluids, oral as well as parenteral drugs for a total duration of 3 days, after which her complaints subsided. She had also received 4 IM injections over 2 days, and she was discharged home. 2 days after the discharge, she developed labor pains and she came to the hospital. Baby was delivered within 2 hours of arrival. The labor was of spontaneous onset and she had a normal natural delivery, and duration of labor was for about 3 hours. Second stage of labor, she said, was of a very short duration. Birth weight of the child was 910 gram, delivered at 26 weeks gestation. It was a female child who cried at birth. Child was shifted to NICU immediately in view of respiratory distress and for preterm care. Mother was informed that the child did not require any resuscitation but had received medication for lung expansion. Postnatal history, baby was received in NICU. After 6 hours, the same medication for lung expansion was supposedly repeated and baby was shifted onto mechanical ventilation with additional medication to aid the child's breathing. Child's parameters showed a possibility of infection and hence the attendants were informed that the baby was started on IV antibiotics. Ultrasound cranium and abdomen was reported to be normal. Mother had given colostrum on day 2 of life. She witnessed the child being given phototherapy on the 4th day, and by day 5, the child was weaned off the ventilator. Mother saw that the child was on nasal prongs and feeding tube. Expressed breast milk was given via OG. By day 7, child was further weaned onto room air and kangaroo mother care was initiated. During the 2nd week, child had multiple episodes of apnea, for which she required oxygen that was being delivered through a machine into nasal prongs. Screening echo was done, which was said to be normal, and child was weaned to room air by day 17. Kangaroo mother care was continued throughout the period. That ROP screening was done on day 15 and mother was told that the screen was abnormal and that screen had to be repeated after 1 week. The repeat screen showed that the right eye had ROP which required laser correction, while the left eye, which also had retinopathy of prematurity, did not require any immediate correction. This is a picture of the mother giving kangaroo mother care for her baby. Feeding, the mother had given colostrum, which was used for colostrum swabbing on day 2. Express breast milk was given via NG tube on day 3. And trophic feeds were advanced subsequently. And from day 5, child was started on larger quantities of express breast milk. Trial Palladai was started from day 16, when her milk was also being fortified. Trial DBF was done on day 19, but because of poor suck, the child was given non-nutritive suckling. Child was allowed to undergo NNS. Currently, the child is on EBM that is being given via Palladai as well as OG feeds. Child has also been started on calcium, phosphorus, and multivitamin supplementation. Nutritional intake. Currently, the child is receiving approximately 10 feeds of 20 ml each, EBM along with HMF fortification, 30 ml per sachet, and which is being given via OG as well as Palladai, along with multivitamin drops, which meet her required caloric and micro and macronutrient requirements. Family history, the parents were of non-consanguineous marriage. Mother's age was 23 years and father's age 30 years upon conception. There was a history of previous preterm. It was a late preterm gestation and this was 1 year ago. So it led to the birth of a boy baby weighing 2.3 kilos who is currently alive and well. There is no history of abortions and there's no history of infant death in the family. Socioeconomic history, according to modified Kuppusamy scale with income modification of 2021, they belong to upper lower class. Both parents have completed high school education. Summary, the baby is an extreme preterm girl born of spontaneous onset labor, which was a precipitate labor with history suggestive of probably placenta previa with maternal anemia, undernutrition, and inadequate birth spacing. And the child had respiratory distress since birth, which was probably respiratory distress syndrome, with a history of prolonged intubation, recurrent apnea, and retinopathy of prematurity. Sir, I would like to move on to examination.
Yes, please.
General examination, the child's cry and activity was fair. Posture is supine on nesting with the upper limbs flexed and lower limbs mildly extended. Child was awake with normal color and comfortable in room air. Vitals, temperature measured using a thermistor probe was 37.2 degrees Celsius. Heart rate was 130 per minute. Pulses were felt in peripheral vessels and there was no brachiofemoral delay. Blood pressure was 62/44 with a mean arterial pressure of 50 mm mercury measured in the right upper limb, and capillary refill time was less than 3 seconds. Respiratory rate 46 per minute. Abdominothoracic type of respiration, and the child exhibited periodic breathing. Saturation 97% in room air measured in both right upper as well as in left lower limbs. Anthropometry, the child's head circumference was 29 centimeters, weight currently 1.190 kg, length 37 centimeters. Head circumference fell on the 50th centile, and length between the 10th and the 50th centile, and the weight also between 10th and 50th centile according to Intergro 21 chart. Weight gain of approximately 15 grams per day. Head to foot examination. Child's hair appeared normal. Head was normal in size and shape. Anterior fontanelle was open, measuring 3 × 3 centimeters. Face was normal. There was no dysmorphism. Eyes are normal. Ears are appropriate for age. Oral cavity was normal. There was no cleft lip or palate, and the neck appeared normal. Breast bud was appropriate for the postmenstrual age. Skin contained a few loose folds. Umbilicus was inverted. There was no redness or discharge. Divarication of recti was present. External genitalia was appropriate for the postmenstrual age. Labia majora and minora were equally prominent. No limb abnormalities were seen. IV cannula was in situ in the left upper limb. Spine was normal. Anal orifice is normal, and orogastric tube is in place. Systemic examination, respiratory system. Chest wall appears symmetrical. Movements were equal on both sides. Bilateral air entry was equal. Normal vesicular breath sounds were heard, and there were no added sounds. Cardiovascular examination. Apical impulse was felt in the left fourth intercostal space. It was lateral to the midclavicular line. There was no precordial bulge. First and second heart sounds were heard. There was no murmur that could be appreciated. Abdomen. Child's abdomen appeared distended. All quadrants moved equally with respiration. Abdomen was soft on palpation, not warm, not tender. Hernial orifices were free. Liver span was 4 centimeters and spleen tip was palpable. Bowel sounds were present on auscultation. Central nervous system examination. Child is awake and observing the environment. Posture. While lying on the warmer, the child was having the upper limbs flexed and lower limbs partly extended. There were spontaneous symmetrical movements of all 4 limbs. Cranial nerve examination. First examination was first cranial nerve was not, olfactory nerve was not tested. Second cranial nerve, the child could fixate on bright light and occasionally on the mother's face. Bilateral pupils were equally reacting to light. Third, fourth, and sixth cranial nerves, extraocular movements were full and free. Trigeminal nerve, child could perceive sensation on the face. Sucking reflex was normal. There was no facial asymmetry. Child had startle reflex to loud sounds. Gag and swallow reflexes were present, and child could freely turn its head in all directions. Suckling was present. Eliciting the neonatal reflexes, rooting and sucking reflex was present. Palmar and plantar grasp was present. Stepping and placing reflex was present. Gallant reflex was present. Glabellar tap was present. Asymmetric tonic neck reflex was incomplete. Morose reflex was incomplete but symmetrical. Motor system examination. Tone on passive movement was appropriate for the gestational age. Tone is normal in vertical and in ventral suspension. Head lag was present when pulled to sit. Bulk was symmetrical throughout. Bilateral knee jerk was brisk, and bilateral plantar reflexes were extensor. This is the examination of child in ventral suspension, and child when being pulled to sit. Diagnosis: the child is an extreme preterm baby with extreme low birth weight, appropriate for gestational age, with recurrent apnea and retinopathy of prematurity. There is no clinical evidence of hearing loss or motor abnormalities. Child is currently tolerating enteral feeds and gaining weight.
So excellent presentation, Dr. Harini. So I must not hesitate to say you presented
Sir, not audible, sir.
Am I audible now?
Yes, sir. Yes, sir. Thank you.
Yeah,
sir.
excellent presentation. I must not hesitate to say that you almost presented like DM neonatology or DNB neonatology fellow. So congratulations. So I think let us start with your history part. Okay. You have got anything more to add, or shall I start the discussion?
Nothing specific, sir.
Okay. Okay.
I have the investigations of the child if it is required during discussion for.
Yeah, we will do it later. So now let us discuss about the history part, and then we will come to the examination. Dr. Sendil, shall I start?
Yes, sir. Yes, sir. Yes, sir.
Okay. Okay. Fine. So I'll finish the discussion of history part. Then if Sendil has to add anything, Dr. Sendil will add. After that, we'll go to the examination part.
Yes.
Okay.
Yes.
Right. So just go to your first slide. Yeah. So whenever you introduce the baby, it is better to say in the very first sentence itself. So baby of so and so. The postnatal age of the baby is 32 days. As appropriately, you put 32 days. Better, terminology would be to say postnatal age is 32 days.
Weeks and so.
Postnatal age is 32 days. Born at 26 plus 4 weeks gestation, and current post menstrual age is this many weeks. Okay,
Yes.
30 weeks plus so or so. Okay, so that will give an idea. So do you know why we need to know the postnatal age of the baby, gestational age, and post menstrual age? What is the significance of knowing it? First of all, what is postnatal age? What is post menstrual age? What is gestational age?
Postnatal age is the number of days of the baby after birth. That is
Yes,
starting
very good.
from the date of birth. Post menstrual age is calculated from LMP in terms of weeks of gestation. And that indicates the maturity of the child. That more likely corresponds with the maturity of the child.
So what do we use it for, post menstrual age? Clinically, as a clinician, as a pediatrician who is taking care of the baby, why you are interested in knowing the post menstrual age of the baby?
Sir, neurological development of the child would correspond to the post-menstrual age rather than the postnatal age.
Very good, very good. So neurological development, especially in a growing preterm, you would be interested in starting interested in feeding skills of the baby, right? So the feeding ability skills of the baby varies with the gestation of the baby, that is post-menstrual age of the baby. So this baby is born at 26 weeks. So when this baby reaches a particular gestation only, you will be considering starting palatai feeding in that baby, and then oral feeding when it reaches post-menstrual age of so many weeks. That's why you need to know the post-menstrual age. So that's why upfront itself, if you mention the post-menstrual age in just in weeks, that will be better. So what is the significance of knowing postnatal age?
Sir, it is important for our screening purposes, for
what screening?
For us to calculate the weight gain per day.
Why? Screening, you told, right? Right. What screening? For what screening?
ROP screening is
Very
done
good.
after 2 weeks.
Very good. So ROP screening, ultrasound screening. Okay. So all these things are based on postnatal age. One more thing is based on postnatal age. What is that? Postnatal age or
Vaccination should
yeah,
be-
vaccination is also based on postnatal age or chronological age. Okay. What do you mean by corrected age?
Corrected age is after correcting for 40 weeks of gestation, whatever is the current age of the child is the corrected age.
Okay, what is it used for?
For assessing the developments, developmental
good.
milestones would correspond to the
Very
correct-
good, very good, very good. Okay, right. Fine. So just move to the next slide, please.
Sir, shall I add, sir?
Yeah, please. Yeah, please.
Harini told
Yes,
LMP decided gestation, right? Okay. What do you think the best obstetric estimate would be?
Sir, sorry, sir.
So best obstetric estimate, which will you take as more accurate in calculating the gestational age of a baby? You have, by accurate, you are told 26 weeks, 4 days.
Dating
Right?
scan.
Fantastic. Best obstetric estimate can be taken from, which is very accurate, to about 2 to 3 days. That is dating scan in the sense first trimester.
Dating scan in the first trimester. Please.
In your baby, it has been done.
Yes, sir. Dating scan was done, but it was done at the 10th week of gestation, sir.
Even by 10th week, they say it is the accuracy. What they say is, yeah, first trimester followed by early second trimester ultrasound is very accurate. Then only your early second trimester ultrasound, your actually in first trimester it will be around 2 to 3 days. There may be a variability. In second trimester, early second trimester, early, it's not late. Early second trimester maybe 3 to 5 days. About your LMP derived EDD, you may get even 1 to 2 week difference. 7 to 10 days, even 14 days you may get. You know the reason. Because almost most of our Indian women are anemic. They may have irregular periods. So we may not derive accurate expected date of delivery. Okay. See, for primary care persons like us, gestational is very, very important, you know, because if the baby is born before 26 weeks, things are different. If the baby is born after 26 weeks, we will be giving our heart and soul to save the baby. Almost less than 25 weeks, even if you put your heart and soul, your expectation, the outcome may be the other way. So calculating gestation is very, very important. Have you done any manual? This baby is now 32 days old. Let us take, no, you don't know the LMP, you don't know first trimester scan. Can you calculate the gestation by clinical examination alone?
Ballard score can approximately estimate the age.
Can it be done by 32 days? Can it be done by 32?
No, sir. It should be done within the first day, preferably, or at least in the first 3
We will
days.
discuss this part in examination. No?
Okay, sir. Yeah. Okay, then the obstetric estimate I thought of teaching them. Yes, we'll move. Next slide, Mark.
Next slide, please. Okay, fine. Right, go ahead. Move to the next one.
Sir, not audible. Sir.
Move to the next one. Next slide, please.
Yes.
Move to the next slide, please. I want that antenatal details. Next slide. Yeah, fine. So you told dating scan done at 3rd month of gestation, around 10 weeks, fine, consumed vitamin supplements. And so what is the significance of asking presence of pet animals at home and all that?
Sir, presence of?
Pet animals at home?
So toxoplasmosis is transmitted by cats, and if it occurs in the first trimester, it can cause effects on the fetus. Sir.
Fine. Okay, right. When you spoke about second trimester, yes, please move to the next slide. Yeah. So there was a spotting noted at 22 weeks of gestation, right?
Yes, sir.
I mean, okay. And then again in 3rd trimester, mother went with features of preterm labor.
Yes, sir.
Okay, fine. So, and she was suspected to have low-lying placenta also.
1
Yes,
minute,
yes.
Chandra. Can I take a minute?
Yes, ma'am. Yes, ma'am.
Yeah, in this history, which she said in the first trimester, now they tell us to add history of travel also, because Zika virus has also been added to the armamentarium of torch.
Okay. Okay.
I mean, especially if there is microcephaly. Otherwise, I don't think it will be relevant. Okay.
Okay, ma'am. I think during this pandemic, you also probably should say, in addition to your TT vaccination, whether mother has received COVID vaccination, right?
Yeah.
Okay. So that's what I insist my fellows to say, like when they present, because it is relevant. Okay. So coming to this third trimester part, when she presented with leaking PV and bleeding PV, anything else you want to say here? It has to be a bit more elaborate. You did a fantastic job, but I feel this can be a little bit more elaborate when she presented at 25 weeks with symptoms of preterm labor, imminent preterm delivery.
Actually, sir, she had bleeding, but it was not associated with abdominal pain, and leaking was a few drops.
Okay.
She did not perceive a draining which was going on, sir.
Okay.
And the symptoms lasted for approximately around 3 days. That is for 2 days when she was at home. Then after she got hospitalized, she continued to have the symptoms for 1 day. And then during which time already she was receiving treatment. And then subsequently her symptoms abated. And she continued to receive the treatment over the next 2 days. And then she was discharged home. She did not continue.
Fine, all that is fine. What I would like to know is, whenever a woman presents with preterm labor, the first thing we have to consider is whether there is risk of infection for the fetus. Okay. So you need to identify if this preterm onset of labor is due to any undergoing infection in the mother. Okay, it is because of maybe due to chorioamnionitis or any other any other infection in the mother. So it is pertinent that you always elicit a history, whether any history of fever is there, whether a mother had any abdominal pain or tenderness, even though there is a little bit of vaginal discharge was there, whether it was foul smelling or not. So these things are important. Okay. So history of fever, history of abdominal pain or tenderness, any foul smelling vaginal discharge. So these history to be added whenever a mother presents with preterm labor, because this chorioamnionitis is one of the major cause which will eventually result in preterm labor, and it will lead on to more complications in the baby.
Yes, sir.
Okay, right. So, and then you told that mother received 4 IM injection over 2 days. That is probably, you mean, antenatal steroids, right?
Yes,
so
sir.
any other drug is relevant? Any other history you need to ask here? Any other drug which has to be administered antenatally, which is which will have implications on the baby?
She might have been given max. I mean, she should have been given magnesium sulfate, sir.
Okay. So what is the role of magnesium sulfate? How does it help the baby?
It is neuroprotective, sir. It improves the neurological outcome of the child postnatally.
Okay.
Reduces the incidence of cerebral palsy in preterm children.
Very good, very good. So it reduces the incidence of cerebral palsy, especially if given for gestation below 32 weeks. After 32 weeks, it may not have a major role. Okay, right, yes, fine. So anything else you want to add, Senthil, here?
It's okay, sir. It's okay, fine. Three things: antibiotics, first, until proved otherwise, premature labor, without any premature labor, please rule out infection. Look for all the doors. Okay, that's the thing. Rule out infection.
Has this mother received the vaccine, COVID vaccine?
Yes, actually, I did not mention, but she received her COVID vaccination during her 5th month of gestation, and we had actually asked whether she had fever post-vaccination, but she did not give any positive history for fever, sir. But she had, along with first dose of PT, after around 1 month, she had her COVID vaccination done.
So what is the vaccine recommended by Government of India for vaccination of pregnant and lactating mothers?
When it has to be given, if it is so.
Covaxin is being given at
Yeah, Covaxin is recommended. Yes. Why?
sir, it's a subunit vaccine. It's not a live attenuated like Covishield. I mean,
It's not subunit vaccine. It's a killed vaccine.
Killed
Hmm?
vaccine.
Yeah. Okay, it's not subunit. It's a whole virus which is killed. Virion is killed and it's a killed vaccine. The other one which is available in Indian market is Covishield, which is live attenuated. So because there is risk of something called as fetal inflammatory syndrome in mothers exposed to antenatally exposed to COVID. So there may be a theoretical possibility if you use live attenuated vaccine. That's why Covaxin is being recommended. Okay.
When
Right.
is it recommended exactly, and how many doses?
So it is it is not different from the dosage is like other adults only, sir. At 6 to 8 weeks
Exactly when,
interval,
yeah,
6
when
to 8
you-
weeks interval, 2 doses, and they don't administer during first trimester. After that, she can get vaccinated. Lactating mother can get vaccinated at any time.
First trimester is not given. So
Yes, sir. Okay, please move. Go ahead. I'm not able to see your slides now. Have you stopped sharing? Dr. Harini?
Hello.
Dr. Harini? I think we have lost her connectivity. Okay, we can ask in the meanwhile some questions to Dr. Jayaprada and Dr. Nivedita. Anything else you want to add, Dr. Jayaprada, Dr. Nivedita?
So what antenatal steroids you use? What is the Indian recommendation? Our national recommendation? Dexa or beta?
So in India, we are it's recommended only dexamethasone. We don't have betamethasone because betamethasone acetate is to phosphate 1:1 concentration is not available in India.
Okay, what is the dose? What schedule you follow, ma?
In dexamethasone, 6 mg is given IM every 12 hourly for 4 doses. Sir. For betamethasone, for betamethasone, 12 mg is given IM every 12 hourly. In fact, every 24 hourly, 2 doses are given.
Gestation?
Yeah, from 24 weeks to 34 weeks of gestation.
Good.
So when do you call it as complete course? Course has been completed.
Sir, after giving the 4 doses of steroids, course is completed, sir. But the pregnancy should happen at least 24 hours after completing the course for the steroids to have an effect on the.
Okay, so after 24 hours and within 7 days of administering steroids, delivery should happen. Okay.
What all the morbidities it can prevent?
So it can prevent intraventricular hemorrhage, necrotizing enterocolitis, and RDS, respiratory distress.
Respiratory distress syndrome.
And reduces mortality also.
Yes.
Okay, so you are ready with your slides? Can you share your screen now?
Yes.
Is there any problem in sharing screen? Then we can go ahead just like that we can discuss. Is there any problem?
No, sir. I mean, I have issues with my internet, sir. So
Okay. Then let's not waste time. You may keep trying, but we will discuss the case. Okay. So mother was discharged and she came back after 48 hours and delivered the baby, right? That's what you told, I think. No?
Yes, sir. Yes, sir.
Okay, okay. So what is the duration of rupture of membrane in this mother?
Sir, the rupture of membrane happened just prior to the delivery, sir. She did not have premature preterm rupture of membrane was not present.
So what is preterm rupture of membrane? What is prolonged rupture of membrane? What is pre-labor rupture of membrane?
Sir, after the onset of stage 1 of labor, if the membranes undergo rupture, then it is pre-labor rupture of membrane. So, and
Sorry. After the onset of labor.
Sir, in the first stage of labor, after the onset of labor pains.
So pre means you have to say before, right? Before something. Why you are using after? Okay.
Right.
So what is preterm rupture of membranes then? First you tell that. We will start with the simple one.
Prior to 37 weeks of gestation.
Okay, very good. So prior to 37 weeks of gestation, if there is rupture of membrane, you call it as preterm rupture of membranes. Okay, right? So what is pre-labor rupture of membrane? What is prolonged rupture of membrane? Prolonged is what? It is self-explanatory.
Is more than 18 hours.
Okay, more than 18 hours. Some say more than 24 hours, but anything more than 18 hours is significant. Okay, fine. Then what is pre-labor?
Sir, I think we should ask stages of labor, then she will be correcting her own statement.
I think we should not encroach too much into obstetrician field.
Then she
The answer is there in the
doubt.
question itself.
Pre-labor rupture.
Yeah, prior to onset of labor. That's all. Okay. So in a preterm, that it can be P, or OM. Okay, it can be it can be pre-labor, preterm, premature, prolonged rupture of membranes. Okay, right? So all these things are important. So if there is prolonged rupture of membranes, especially in this lady who got admitted at least for 3 days before the exact delivery happened. So if it was prolonged rupture of membranes, then it has got implications for the fetus. So that's why you need to ask history whether there was clearly leaking and whether it is suggestive of prolonged rupture of membranes. Okay.
Doctor, kindly tell me when to move the slides.
Yeah.
You go to the next slide, please. Now, I think 6th or 7th slide we were at. Now you are at 4th slide. Can you go to the 7th one, please?
When we routinely ask history, what if you ask why discharge like that, they will say, please, whenever you take an history, you be clear. Recently, is there any change? Recently, they will say, while it's like passing urine alone, whether it was associated with any fever. That's what we people are worried about, fetal infection. Why we are worried about premature rupture, all those stuff? Because we are suspecting some chorioamnitis. That chorioamnitis would have caused some fetal inflammation, which is more worrying, because which definitely affects our neonate's outcome. Though it has been given Maxelf, though it has been given antenatal steroids, when there is a strong background evidence of chorioamnitis, that too, when it is associated with foul-smelling liquor, we are going to face difficult postnatal period. All these we can prepare our mind, we can manage our baby accordingly. Okay.
Please change the slide, no?
You can come to the slideshow. Excuse me.
Sweta, please move on slide. So number 7, you're asking number 7?
I think it was 7th or 8th slide. Yes.
Yeah, Harini, meanwhile, can you tell us what are the predictors if for preterm labor? In this mother, did she have any predictors to say that this delivery will also be preterm?
Ma'am, she already had a child who was born late preterm.
What is the
And,
chance then for second child to have to be preterm? What is the percentage?
more than 50% chance that
I don't know whether it is as high as that. I think it's 30. Chandra can
30.
correct me.
Yes, ma'am. It's around 30%.
Yeah.
30.
And then any other predictor is there? You know, there are some predictors.
there was low interpregnancy interval, ma'am. There was narrow, and mother was already malnourished, anemic.
Yeah,
And
something.
placenta was also low lying.
Okay, these are all very general. Anything else is there?
She had multiple episodes of antepartum hemorrhage. There was spotting on.
Okay, all risk factors. These are all risk factors. What I'm asking you are predictors.
Any measurement like that?
Yeah, any measurement, any thing you can take and check
Yes.
from the vagina.
Biochemical.
Radiological or biochemical imaging.
Any FFN you've heard of? You've heard of something called fetal fibronectin? Yeah, okay. So that they can check. That's normally not supposed to be there. So if it is there, that means the the fetus has got separated and it is ready to come out. Okay. So that's like a glue which fixes the fetus to the placenta, I mean to the uterus. And if the secretions are present, that means the fetus is displaced and it is going to be delivered anytime. Okay, then your thing also, bacterial vaginosis if there is, and your cervical length. Okay, so these are some of the predictors that they have a very high predictive value for telling whether this child is going to be a preterm or not. Okay, go ahead.
Next slide, please. Please go to slideshow mode, no? Ms. Sweta?
Can you go to full screen, please?
Can you hear us? Enable
Yes,
editing.
yes,
Click
doctor.
enable editing. Click enable editing. That yellow ribbon is there, no? That click enable editing. Enable editing.
Actually, on the top, I'm having other options that.
No,
to move
enable
that.
editing. You click that. Enable editing. That yellow thing is seen, no? In that enable editing one.
Yeah.
Now you go to slideshow.
Yeah.
Slideshow, this one. Slideshow.
Bottom or up anywhere.
Or press F5. Press F5.
Not working on my laptop, so.
Okay, then click this slideshow, no? Next to animation slideshow is there, no? Click that.
Actually, on my screen, no, on the top bar, I'm having this options, mute, start video, and all those.
Okay,
Bottom,
okay. Then press F5, no? F5 in the
That is
keypad.
not
Press
happening,
F5.
so
F5 not happening.
I'm trying from my end, actually.
Well, okay, fine. Let's not waste time. Okay, you go move to the next slide. Yeah.
Move to the next slide.
Yes. Yeah.
7th.
Shall I?
Are you ready now?
Yes.
If so, you can share. Yeah.
Oh.
Yeah. Next slide, please. Fine. No, the previous one. The previous one. Yes. So, baby, short duration of second stage of labor, and then baby cried at birth, and birth weight was 10 grams. So, anything else you would like to say in the something which is relevant for resuscitation of a preterm baby? And do you mean that baby received medication in the labor room itself for lung expansion?
Yes, sir.
Okay. So baby did not require any positive pressure ventilation, but baby required surfactant in the labor room itself.
Actually, positive presentation was given, but parents were not aware of it.
Okay. Fine. Okay, if you are provided the details of resuscitation by the resident doctor who had attended the delivery, what are all the details you would be interested in knowing?
Especially
sorry?
in this 26 weeker.
So in a 26 weeker, what are all the details about resuscitation you would like to know?
So whether the child cried at birth, whether the child had umbilical, delayed umbilical cord clamping.
Very good.
Whether
Delayed
the child
clamping.
received. Sir,
Yeah, go ahead. I think you are again on 2 devices. We are hearing a lot of echo.
just a second.
Take care of that and then please go ahead. One is delayed umbilical, delayed cord clamping. Yes. So do you know how long it is recommended for a preterm baby and beyond what gestation it is recommended?
Doctor, unmute yourself.
So
I think we have a lot of connectivity issues today.
hello.
Dr. Harini, are you there?
Delayed cord clamping is recommended for 60 seconds.
So what NRP says, a delayed cord clamping for at least 30 seconds. At least 30 seconds. Okay, it can be up to 60 seconds also. Okay, right. Then what else?
Apart from that, whether the child has received.
Rini, you cannot be on 2 devices. You are
again on 2 devices. You log out from one device, no?
Continue now. Continue.
Continue.
Can I hello?
I have muted. Continue, doctor.
Can I proceed with the PPT with my device and answer on the other device? Sir, I will mute this device. That way there won't be any disturbance.
So you don't want to share screen now?
No, sir. I will share my screen and I will answer from the other device.
You will answer from?
From the
no problem.
No problem. As long as there is no echoing, we have.
Now it's perfect. You can speak now. No problem.
Yeah.
Yes. Go on now. You told crying at birth and delayed cord clamping. Anything else?
And whether the child received delivery room CPAP and delivery room early surfactant, and whether the child has been administered 1 mg vitamin K. Warm resuscitation. Warmth, and whether the child has been wrapped in plastic bag, occlusive wrapping has been done.
Okay, good. So anything about the oxygen FiO2 which was used during resuscitation?
This child was less than 30 weeks, so child can be resuscitated starting from 21 to 30% of oxygen, depending on the target saturations being reached.
Okay, very good. Okay, fine. So do you think the timing of surfactant administration is appropriate?
So, considering that this child is an extreme preterm, prophylactic surfactant has to be administered as soon as possible, sir. So, delivery room surfactant is indicated in this child.
Okay, fine. I mean, maybe for your level, MD level, probably we can accept this answer. But as neonatologists, what we would say is like there is no role for prophylactic surfactant anymore. So these babies will be started on delivery room CPAP and they will be shifted to NICU. And what the strategy which is being followed now is early selective surfactant therapy. Okay. What do you mean by that is you put the baby on CPAP and then you decide surfactant only if there are certain criteria are met. If on CPAP, if the baby is requiring FiO2 of more than 40%, then only you will, and if blood gases are not acceptable, then you will start administer surfactant. Or if the baby had required intubation during for resuscitation purpose, then on all those babies you administer surfactant. Okay, so what we follow nowadays is called as early selective surfactant therapy, not prophylactic surfactant. Okay,
More because of your, if you are proper, if the mother has received proper antenatal steroids, this prophylactic surfactant and your early CPAP from the delivery room, all these may reduce the need for prophylactic surfactant.
so this early CPAP almost reduces the need for surfactant by almost 50%. So we don't administer surfactant in these babies prophylactically. Okay. And also there is some evidence that prophylactic surfactant may increase the risk of bronchopulmonary dysplasia. So we won't administer prophylactically nowadays. Okay. Okay, move to the next slide, please.
What device you use to deliver CPAP in delivery room? Ma? Do you know the name of the device?
Neopuff, TPs.
TP resuscitator. Okay. Do you have blender in your labor room?
Yes, sir.
Blender. You use it. When you are resuscitating a preterm, you use it.
For extreme preterm,
Okay. You practice plastic wraps?
so when there is high risk for extreme preterm, then we will take, sir.
Oh, yeah, go ahead.
Yes, sir, for extreme preterm deliveries.
Extreme in the sense less than 28 weeks. What is the recommendation?
Less than
For any less than 32 weeker, you can use plastic wraps. Why?
It prevents the drying up of amniotic fluid, sir, and it maintains the it prevents evaporation of.
So the evidence is very clear that the admission temperature of a preterm less than 32 weeks is one of the major factor in babies. You can predict, one of the major predictor in finding out your mortality and morbidity profile of that particular baby. This admission temperature. You know what you are supposed to do even before clearing your amniotic fluid. You are supposed to receive the baby in the plastic wrap up to the neck, and in the face you can clean it up and you can keep the neopuff or the so-called TP resuscitator, and you can deliver PEEP. And most preferably supposed to be transported in a neonatal transport incubator to our NICU as soon as possible. Fine. Next slide. Yeah, this is okay, sir.
No, yes. Okay. So after 6 hours, your baby received one more dose of surfactant, right?
Yes.
And baby was on ventilator.
Yes.
Okay, and baby was ventilated till for how many days?
Totally 5 days, sir. That is including the weaning, and it was extubated on day 5.
Okay. So extubated on day 5 to CPAP.
Extubated onto CPAP.
Okay.
Yes, sir.
Okay.
CPAP with nasal phones.
Okay. So when baby is on ventilator, any other details you would like to know?
Whether the child had what was the pressures that was set for the child, what was the FiO2 requirement that the child had, whether it was difficult to wean the child, whether the child had adequate resolution of the respiratory distress when the child was on ventilator, whether the child had any episodes of shock or any requirement of inotropes.
So pertaining to ventilation, if you have access to data, it will be interesting to know if the baby, what are the settings, what was the maximum setting, and what was the maximum FiO2 baby required. Okay, so PIP and PEEP, what was the maximum baby required and what maximum FiO2 baby required. So that would help us to indirectly arrive at to know the severity of RDS which the baby had. Because baby had received 2 doses of surfactant, probably baby would have had moderate to severe RDS. So that's why baby had received 2 doses of surfactant. So knowing the pressures required also will be helpful in knowing, what would be the degree of RDS the baby has had. Okay, right. So, and the mode of ventilation, that is also important. If you have access to the data, so you should always say what mode of ventilation was on. Baby was on a synchronized mode of ventilation or non-synchronized mode of ventilation, and what were the settings. Okay, all these have got implications for the normal outcome of the baby later. Okay. So, and if any blood gas details were available, that also will add to the kind of information which we have. Okay. So if you have access to blood gas parameters in this baby, what is the one thing what are the 2 things which you would be kind of interested in knowing?
Extent of respiratory acidosis that the child had, pH, whether it was severe acidosis or.
Okay, we are worried about acidosis, alkalosis in any baby. For pertaining to a newborn preterm, 2 things which you are very much worried.
It is long term.
Which has long-term implication. So one is hyperoxia. Okay. One is hyperoxia because that will cause free radical injury that can predispose baby to develop ROP, BPD. The other one is hypocarbia. Okay, if the baby is overventilated, oxygen saturations may be normal, but you may be overventilating the baby and washing out CO2 from the baby, causing a lot of hypocarbia. So this hypocarbia will reduce the cerebral perfusion and in turn increase the risk of developing periventricular leukomalacia in preterm babies. That's why you should always try to prevent hyperoxia and hypocarbia in a baby who is on ventilator. Okay. Are you there?
Yes, sir. Yes, sir.
Okay, fine. Yeah. So then you have stated that baby underwent ultrasound cranium. I mean, any other intervention was done for the baby. That is also pertinent. Any umbilical lines, anything was put for the baby?
Yes, sir. Child had an umbilical venous catheter that was inserted. It was in situ for 5 days and then.
So that history also you should always include. Okay, any intervention in the baby has to be mentioned. Okay, because if in future baby develops some complications, we may link to that complication all these interventions. So always you have to mention it. Okay. So when normally this ultrasound cranium has to be done in this baby in preterms?
Within the first 6 hours of life and repeated after 72 hours. That is by the 3rd day, ultrasound should be repeated.
Yeah, within first 20 to 24 hours is enough. I mean, within 6 hours may not be possible in all setup. So we would want a neurosonogram to be done on day 1 and then one at day 3. If day 1 is not possible, definitely, I mean, you should do it on day 3. Why is it so? Is there a scientific reason behind it?
Intraventricular hemorrhage IVH can be detected. At least 50% can be detected on day 1 and approximately 75% can be detected by day 3.
Around
Yeah,
80.
so yeah, it is close to 80 to 85% of all hemorrhages have happened within first 72 hours of life. So if you are not able to get an ultrasound on day 1, you get it done on at least day 3. Okay. So baby received phototherapy also, right? So what do you think these preterms, why they are at a high risk of developing jaundice?
They have got a lot of complications which will increase the incidence of hyperbilirubinemia, hypothermia, hypoglycemia, dehydration. Everything can cause hyperbilirubinemia to get precipitated in a preterm child.
So these are all additional risk factors which can increase the risk of bilirubin induced neurotoxicity. Okay, but the basically jaundice is more common in preterm babies due to some other reasons. What are they?
Major contributors. SAR is asking major contributors.
Increased hemolysis.
Why there is more hemolysis? Why there is more hemolysis in preterm? Hmm?
Shorter RBC lifespan.
Yeah, very good. Shorter RBC lifespan. Okay. Then
Anything we do repeatedly.
Sampling.
That causes anemia, right? But yes, short lifespan. Then good. In half an hour there, sir. Should
okay.
And
Right.
can you just tell us why bilirubin encephalopathy is also more common in these children?
Immature blood-brain barrier. There is very poor structural support, and child enters an anabolic state later on. A preterm child enters into an anabolic state at a later date. So, because of which the bilirubin can easily enter it and cross the blood-brain barrier and cause encephalopathy.
Okay, you said defective blood-brain barrier. Then what else?
Immaturity of the liver enzymes.
Okay. Okay. Then anything else?
Gastroparesis, which increases enterohepatic reuptake of bilirubin.
Okay, that's a small
The
note.
motility of intestines is lesser in a preterm unit than a term unit.
What is less?
Intestinal motility.
Okay, what about anything else? These are all small things. Hypoalbuminemia. Okay, hypoalbuminemia. Okay, so the binding sites are less, and when these babies go in for hypothermia, there is a release of free fatty acids that will displace the bilirubin from its binding sites. Okay, so when there is more free bilirubin, there will be more bilirubin toxicity. Okay.
So whenever you discuss about jaundice, you should also say that what is the blood group of the mother and baby here. There is no blood group incompatibility. So you cannot assume that in a jaundice in a preterm baby is because it's due to prematurity. There may be other factors also, which always you should look into in any case of jaundice. Okay.
Yeah, they're all aggravating factors. So there must be a basic pathology, and then all these will add to it. Okay.
Fine. And then do you know what charts you will use to know the cutoff for jaundice, cutoff of bilirubin?
ABP nomogram.
Which one?
PB 35 plus than other AAP.
So for a preterm 26 weeker, which one you will use?
Values are given.
Any other guidelines you know?
6 to 9 milligram per deciliter would be phototherapy range, and above 9.
Sorry.
So there is a hint in his question. He said any other guidelines. So you can get the hint.
Dr. Nivedita Jayaprada, you can chip in. We have not heard your voices.
Mask, totally masked. Please remove that mask and you can speak.
Unmute yourself. Anybody knows? Okay, so for preterm babies, what we use is like there is something called as NICE guidelines, which is from UK. Okay, National Institute for Childhood Excellence, Child Excellence or Childhood Excellence, NICE guidelines. So that from UK that we use. From America, we have we don't have a chart like this, but we have a table which is also called as Maisel's chart. Okay. Maisel's. Okay, so that we use, that gives the cutoff at different gestation, what should be the range of bilirubin at which phototherapy has to be given, and what the range of bilirubin at which exchange transfusion is indicated. Okay, so do you know, is there any role for prophylactic phototherapy? What is prophylactic phototherapy?
No role has been. No, sir. No.
So there is a role for prophylactic phototherapy. There is no role for prophylactic surfactant, but for phototherapy, there is a role. Okay. Less than 26 weeks, we can start prophylactic phototherapy. Okay. So you want to differ?
Any visible jaundice before doing sampling, because we will end up in giving phototherapy, better to start. Any visible jaundice, start phototherapy. About the measles and NICE charts, though AAP chart are gold standard and grade, it has got grade A evidence. Our NICE and measles, it has got somewhat low level of evidence compared to AAP charts. That's why we were not that much knowing about those charts. Those are approximations.
Fine. So anything else, Dr. Sendil, you would like to add?
Sir, yes, sir, we'll move on. Sir.
Okay, fine. Okay. So fine. So let us come to the focus on the previous slide itself, please. So that's where apnea happened, right? So during the second week. So I want some more description about the event which happened there. So during the second week, child had multiple episodes of apnea. So you should specifically say on what day of life it is. Okay. Is that apnea happened on only one particular day, after that improved? Or, I mean, from this sentence, what I would kind of understand is during the entire week, baby had apnea, multiple episodes every day for the whole week. So how, like, you would want to describe?
Actually, the child was extubated on day 7, sir. Towards the end of the 7th day, child had got one episode of apnea, which required upon lactate stimulation. And then child continued to have apnea on the 8th day of life. It had around 2 to 3 episodes, of which one episode was associated with desaturation, sir. So at that time, child was restarted on CPAP. And why not CPAP? She had one more episode of apnea, sir. And that recovered without any bradycardia or hypoxia, sir. And so she was placed on CPAP and then once again gradually weaned off CPAP. And then she was actually shifted on the HFNC and then weaned off HFNC.
Okay. So we would want to know more details about these events, because apnea had been happening for almost 2-3 days. Whether this apnea can be attributed only to apnea of prematurity, or there could be some other cause, because apnea of prematurity is a it's a diagnosis of exclusion. So we would want to know any other treatable cause of apnea in this baby before considering apnea to be due to apnea of prematurity. So what are all the causes of apnea? Probably can cause, what causes could be there for this apneic episodes in this baby?
Sepsis could have happened, or child would have gone in for hypothermia, or electrolyte imbalance, hypoglycemia, or if the child had intraventricular hemorrhage, or if the child had NEC, opening up of PDA. So septic screen was repeated. Child was already under thermal warmer, and child had that is a screening echo was done, sir, and it was found to be normal. And at that time, child did not have any hypoglycemia or any other significant electrolyte abnormality, sir.
Okay, so all the other secondary causes were ruled out. Anything else you would like to add to this, Kitty? One more important cause.
Seizures. Child did not have tachycardia associated with apnea, sir, and there was no abnormal movements or cyclical or sudden seizures. Or
one more important cause, because baby was ventilated for a week and then was on invasive ventilation. So one more common cause is cause for apnea in these babies: anemia. Okay, so you should always rule out anemia in any preterm on second or third week who is developing recurrent apnea. Okay.
Okay, sir.
Fine. So what was done for this apnea?
Initially, we tried, sir, actually on day 1 of life, the child was started on caffeine. And for this,
what is the point in starting caffeine on day 1? Why caffeine is being started on day 1?
Sir, early caffeine, prophylactic caffeine was given for this child, sir. Early initiation of caffeine is associated with lesser occurrence of BPD and It improves neurological outcome at 18 months.
Okay, very good. So in what babies, in all babies requiring ventilation, we will start caffeine, or like, is there any cutoff?
Less than 1.2.
Okay.
Less than 1.25 kg.
Less than 1.25 and
Less than 30 weeks.
very good, very good. So less than 30 weeks and less than 1.25 kg, we will start caffeine, especially if the baby is on a respiratory support. Otherwise, we will not start caffeine prophylactically. Okay, so this, if you start prophylactic caffeine in this group of babies, it reduces the duration of mechanical ventilation. It reduces the incidence of PDA, reduces incidence of BPD, as well as improves the neurological outcome at 18 months. Okay, right. Fine. I think you will know the dose of caffeine, how much, how long to be given and all that. Okay. So anything else you want to discuss in this slide, Dr. Sendil?
Sir, we'll move.
Okay, fine. Okay. So a little bit describe about KMC. KMC was started when?
KMC was started after the extubation, sir. After weaning off the womb, on day 7, KMC was started for this child, sir.
So what are the benefits of KMC?
So improved bonding between the child and mother, improved feeding, and improved weight gain for the child.
Harini, excuse me. Harini, please come closer to that mic, no? Yeah. Otherwise, you can change your position, please. One of you, please move on. Yeah.
Prevents infection, prevents hypothermia, and improves the bonding between the mother and the baby, and improves the weight gain of the baby. Increased incidence, it reduces incidence of apnea, and it improves the attachment and latching and breastfeeding at the later date when we start DBF. And child can achieve early entrance full.
Okay, so it also reduces the duration of hospital stay, okay, and increases the exclusive breastfeeding rate in these babies. These two are important outcomes. Mainly, it reduces infection, reduces hypothermia, better weight gain, shorter hospital stay, and increases the exclusive breastfeeding rate. Okay, do you know what is mean by immediate KMC, IKMC? IKMC. What do you mean by IKMC, immediate KMC?
No, sir.
So IKMC is otherwise called as immediate KMC, where you start KMC within 24 hours after birth in a baby who is relatively stable on minimal respiratory support. Okay. So immediate KMC has been found to be helpful in reducing mortality in babies born in lower and middle income countries. Okay. But for starting immediate KMC, you need to have something called as NICUs, okay, where the mother also can be accommodated next to baby within the NICU itself, so that the mother can start KMC within 24 hours after birth. Okay.
Yes, sir.
Okay, move to the next slide, please. Anything else, Sendil, you would like to add in KMC? Madam?
Yes, madam. Yes, madam.
Yeah. Now, Harini, when should you stop KMC in a baby?
When the child is uncomfortable and wriggles out of KFC, or when the child has achieved adequate weight gain and has reached 3 kilos of weight.
Okay, we go. Correct. What you said first is correct. We decide when to start and the baby decides when to stop. Okay. Okay. Yes, Sendil, you were asking something.
Yes, madam. ROP, regarding ROP, what is the guideline you practice in your unit? You do screening for all the preterms by 2 weeks. By 15th day, I was wondering to looking at your sites. You do screening for all newborns by 15th. What's your guideline?
Yes, by the second week, as early as possible, we do the screening for the preterm newborns.
For all, even for a 34-weeker stable baby, or 32-weeker stable. Maybe you preferably do at 2 weeks. Routine practice. Is it a routine practice?
Extreme preterm medicine will start.
In this particular baby, yes, understood. Why? Why do you think so? In this baby, particularly in this baby, yes, it has.
Yes, high risk for APROP occurrence.
Why? Why? What's the high risk you think of?
Extreme low birth weight, exposure to oxygen, and mechanical ventilation. Duration of mechanical ventilation was for 5 days in this child, sir. And even after that, child continued to have CPAP and it required HFNC. There was a prolonged oxygen exposure.
So we are sitting in an era of non-invasive ventilation. Okay. We are not nowadays, we don't practice invasive ventilation as a routine. Now we are sitting in an era of non-invasive or least invasive ventilation. That's previously as a routine, we started on CPAP. Now we move to, when the baby is somewhat stable, we move to HFNC. We want to keep both nurses, our nurses and our babies more comfortable and more physiological. Though we give some respiratory support, it has to be more physiological and it should be nurses friendly. That's why we move down to HFNC now. Almost 5 days of invasive ventilation. Definitely it has to be considered. This baby is more prone for, yes, APROP. That is the major risk factor. That's why Sarah has asked you, we are supposed to know if at all, if you have access to look at the patient data, you are supposed to look at the FiO2, the highest required FiO2, how long, then you are supposed to know about the ABG gas values, which all those things may have an impact on this ROP, right? Okay. But as a routine, if you practice by 2 weeks, I think our Optal OP will be flooded up. But in those babies where there is most extreme preterms, where there is more risk for ROP, you're supposed to do as early as 2 to 3 weeks, within 2 weeks or 2 to 3 weeks to rule out APROP. AP is?
Aggressive posterior ROP.
Okay, fine.
So do you know the stages of ROP? Stages of ROP?
Yes, sir. There are from 0 to 5, there are stages of ROP, sir. Earlier being the better. Stage 0 is not
Demarcation line.
Stage 1 is a demarcation line. Stage 2 it's a demarcation ridge. Stage 3 is extra-retinal and fibroplastic. Stage 4 is partial retinal detachment and stage 5 is complete retinal detachment.
4A and 4B. 4A is not involving macula. 4B more than 50% involving macula.
Okay, fine. Okay, wonderful, wonderful. Okay. So when is laser recommended for what ROP?
Stage 3 and above, sir.
And type 1 shoulder ROP.
Stage 3 with plus in zone 2 or stage 3 in zone 1. Okay. Okay. Right. Any other drug you know to treat ROP?
Bevacizumab. Intravitreal injection of bevacizumab.
Bevacizumab and one more. Any other?
What is it? Bevacizumab. What is it?
Avastin.
What is it?
And vascular endothelial growth factor, monoclonal antibody against VEGF.
Anti-vascular endothelial growth factor. Yes. Sarah has asked one more drug.
So there is one more drug like bevacizumab. So what is the complication which is expected by using bevacizumab? Is it better than laser?
No, sir. Laser is only.
So then why bevacizumab is there? When we have to use bevacizumab? So for zone 1 ROP, bevacizumab is better than laser. Okay. If it is a zone 1 ROP, posterior ROP, then we can use bevacizumab. That is better than laser. Bevacizumab has got a lot of systemic absorption also. Even if you give intravitreally, it can reach systemic circulation and may cause some systemic side effects which are not known. That's why the recent drug which is called as ranibizumab. So that is, kind of, it does not reach the systemic circulation. It is there only in the vitreal compartment if injected. So ranibizumab has got less systemic complication. Okay, right. Okay, so we'll go on to the next slide, please. Feeding, yeah.
Yes.
So yeah. Focus. Just go back to the previous slide. I was wondering how this baby, was able to take a Paladai feed on day 15. So on day 16 or day 15? At day 16, what could have been the post-menstrual age of this baby? PMA?
30
It will be
liters,
28. No, it would be 28 plus 5.
28 plus 5, 29.
Yeah, it will be 28 plus 5. I think it's too early to try, even trial Paladai in that baby. So early. It may lead to more complications. Probably, I mean, evidence says that we can try Paladai feeding in a baby earliest by around 31 or maybe 31 weeks, not before that. Okay, so I would say it is probably very early to try Paladai feeds in that baby. I would not be doing that. I would be hesitant to do that. So you mentioned something about fortification. What do you mean by fortification? Why you should fortify feeds in a preterm baby?
Human milk is deficient in a few minerals, vitamins and minerals. So it is preterm milk is a deficiency. So we have to supplement in order to meet the nutritional requirement of the child. That is being done using human milk fortifiers, HMF.
So is there any difference between term and preterm breast milk?
Yes, sir.
Breast milk of a term mother and a preterm mother.
Preterm milk contains increased sodium, chloride, protein, and magnesium.
Okay. So protein content is better in preterm milk when compared to term milk, right? Then why do you add fortifier?
So fortification is required for vitamin D, vitamin A, vitamin E, and iron.
So it is also required for protein. Okay, so if you don't fortify the milk, so the preterm mother's milk also, after 2 weeks, the protein content of preterm mother's milk starts coming down. Okay, so it will not be as high as, it may be as high as 1.7 gram per 100 ml in first 2 weeks. After that, it starts coming down, and by the third or fourth week, it will be close to a term mother's milk only. So it will be around 1.1 gram per 100 ml. Okay, so that's why you need to fortify the milk to meet the protein as well as other micronutrient requirements of the baby. Okay, when ideally you should start fortification?
After achieving full enteral feeds of 100 ml per kg per
So you
day.
don't have to, you have to reach at least 100 ml per kg per day. But nowadays people are starting at a lower volume also. And for what babies you start? Birth weight below what, and the gestation below what you start fortification?
Less than 32 weeks.
Yeah, usually less than 32 weeks and less than 1.5 kilos we start fortification. And how long you have to continue fortification?
40 weeks or up to 2 kgs.
Yeah, till they reach at least 2 kgs. Okay. Do you know any other alternative? Because this human milk fortifier is an expensive thing. Not many would be able to afford, especially those who are delivering in.
MCT oil or coconut oil. MCT oil.
MCT oil. No, you are not supposed to say this answer in exam. MCT oil, coconut oil should not be used because it will just provide empty calories, it will not provide any protein for the baby. It is like, you are feeding Coca-Cola or Pepsi for the baby. Okay, you are giving empty calories, but not extra protein. So we will not use female MCT or coconut oil in baby. So instead, if parents are not able to afford human milk fortifier, we can use preterm formula to fortify milk. Okay. Right. Any other question here, Dr. Sendil?
Yes. Here comes the role for donor milk also.
Yes.
Yeah, so the importance of human milk banking, it cannot be overemphasized at this point. You should know something about human milk banking and all that, and the procedure followed there.
Definitely, definitely. Actually, when the baby started having milk, when the baby is on tube feeds, you are controlling, you are giving timely feeds. So you are going to give measured feeds in accordance to the intake. You cannot go beyond 180 ml per kg per day, even though the baby is tolerating. It's beyond that. If you move, you may face feeding difficulties. But when the baby is taking orally, even when the volume shoots up to 300 to 400 ml per kg per day, you can give when you give mother's own milk or donor's mother's milk. Okay, so about the feeding volumes, the upper limit when the baby is taking orally, you can go up to even 300 to 400 ml per kg per day in a growing preterm. That we are supposed to know. So as a in less than 1.5 as a routine, see what we follow, what we do in our unit is we start as much as early as possible, except what criteria you are supposed to follow is when the perfusion is stable, the baby is having stable perfusion, let it be on inotropes, doesn't matter, stable perfusion, and it doesn't have any fluctuating oxygenation. When both these are stable and the GIT is ready, if there is no active bleed or active abdominal distension, you can start. Nothing wrong in starting beginning feeds. Progression of feeds has to be decided then and then. This is about the feeding in a preterm baby. Yes, sir.
Okay. So if the baby is on full fortification, then this calcium, phosphorus, multivitamin supplement and all may not be required. Okay. So
Yes.
an appropriately chosen fortifier would meet all the requirements, and the baby may not require any more supplement until you wean the baby off this fortifier. Okay. Right. So, and you must be prepared to answer questions on inadequate breast milk, how you can improve breast milk secretion in the mother, and as ma'am told, human milk banking also you are supposed to know. Okay.
Yes.
Oh, fine. Right. So I think we'll skip this part, family and the socioeconomic history.
Yes, sir. Yes.
To the next slide. Right. So anything specific in this summary? I don't think.
Yes, sir. That's why we insisted already that we need post-menstrual age, and we are supposed to know that. In summary, we are supposed to know that extreme preterm alone won't be sufficient. Supposed to know the postnatal age, post-menstrual.
Okay. So then you go to the go to the examination part now. Yes. And when you say retinopathy of prematurity, you are supposed to say the stage. Okay, if you know the stage, better you please mention the stage. Huh? Stage, zone and stage of the disease. Okay. Right. So I think this is fine. Next slide. So this baby was next to mother or was in NICU? This baby was in NICU, right?
NICU.
Okay, okay. So under radiant warmer. Okay.
NICU, but mother was in like KMC wards.
Okay, okay, fine. Okay, 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 right. Right, you can move to the next slide. So there was no jaundice when you examined the baby, right?
No, sir. No, sir.
Okay, okay. So what is your comment on anthropometry? Anthropometry?
It was more or less appropriate, sir. Weight gain was a bit on the lower end, but otherwise.
So what was the weight centile at birth and then now? At birth, baby was 9-10 grams and now 1.19.
Yes, sir. I marked the birth centiles in yellow, sir.
Okay.
Okay, okay, okay. Fine. Okay, so why did you choose to use this intergrowth chart in this baby? Is that policy is being followed in your unit?
Yes, sir, we use intergrowth. Sir, actually, Felton's
doesn't have Indian representation, sir. So intergrowth is
Okay. Even though intergrowth is kind of, I mean, included babies from India, the problem in using intergrowth for babies less than 34 weeks is that they had only very few babies in that study who were born below 34 weeks. To my knowledge, it was handful of babies, around 300 or 400 babies. Okay. So that's why we have not started using liberally intergrowth chart for interpreting growth in this baby, in this group of preterms. Okay. But if your policy is to use the chart, I mean, you can very well use that, but always be prepared to give this answer. Okay. So we still follow Fenton chart. Okay. So what is the difference between this Fenton chart and intergrowth chart? Anything you know?
gestation starts from 33 weeks.
Intergrowth?
Yeah. Intergrowth is included until 63 weeks of gestation. So Fenton's is only until term. It's only until 40 weeks.
No. Senthil, you would like to add anything here?
Sir, audible. It's not audible. Hello.
She says that Fenton starts at only 40 weeks. So Fenton
It's up
also
to
starts
60 weeks. Fenton's is up to 50 weeks.
and starts as early as 24 weeks, I believe.
Yeah, only thing is we can get more children who are smaller because our children are compared to Western, our children are smaller, so they may fall into a lower percentage with Fenton. And I was telling that there's also a Fenton calculator, which makes things very easy for us to just enter, and then you will know what is the appropriate age which is required. That is an online calculator which is also available. So Fenton, I mean, we are all still preferring Fenton. We haven't yet got around to using intergrowth very liberally, as Chandra said.
So if you see weight here in Fenton's Fenton would be in close to less than 10th percentile, I would feel.
Yes.
But in intergrowth it will be higher. Okay?
Yes. Yeah. So we so via media between the two probably will be
okay.
We have our own growth charts.
Yeah. So and this one is a intergrowth is a it is a linear follow-up of babies at a different gestation, but Fenton's is not a linear follow-up of babies at a different gestation. It is not a longitudinal study. Okay, they have been pooled the data for babies born at 24 weeks, 25 weeks. Okay, it is a size at birth chart in otherwise called as. Okay, and they have plotted the data. But here it is a longitudinal study. A baby who was picked up at 24 weeks will be followed up till the baby is 34, 40 weeks or so.
40 weeks.
Okay, yeah.
Yes, sir.
Right. Next, please. Right. Okay. So here everything is fine. So when you are, I think some of the examiners may prefer to know when you are describing the hair of the baby, preterm baby, you should be more, specific. You should use some adjective to describe the hair, scalp hair in a preterm baby and a term baby. And when you are saying about the hair, you should also mention that whether Lanago is there or not in the back. Okay.
So there was bald areas in the back, sir, and hair was groomable. It was thin.
Lanago was there.
Hair was, no, sir. There were bald areas only predominantly.
Bald areas were. Bald areas were there. Okay. Okay.
And
so what
hair
is the
was
difference between scalp hair of a preterm and a term child?
So the scalp hair preterm child is thinner, more sparse.
Yes.
Whereas for
Single
a term that
Thinner, sparse, and one more adjective. If you say that, probably Dr. Paul will give you gold medal.
straight hair.
It will not be straight. Okay. It will be thin, sparse, and smudged. They will be sticking together. Okay. But in a term baby, they will stand out. It will be thicker, dense, and it will each strand will stand out. Okay. They will not be sticking together. Okay. Fine. Okay, move on. And when you describe about oral cavity, always say there is no oral thrush, because these growing preterm, they may have oral thrush, that you have to mention. Whether any pustules are there in the skin, that you have to say.
No, sir. No skin pustules, no oral thrush.
Umbilicus, you have rightly mentioned, there is no discharge or redness, and it is inverted. Fine. And then you should always say there are no hernia. Okay, these small babies, when they are growing, most of them develop inguinal hernias. So that also, or umbilical hernia, that you should mention.
Abdomen. Sir, in abdomen examination.
Okay, fine. Okay, go ahead, please.
Systemic examination.
Fine. We can skip all these things. Abdomen appears distended, all quadrants move equally. Fine, okay, right. Go ahead.
So why you want to mention it as distended? Can it be full?
Looks bit full, yeah, full. Better would be to say it as full.
Okay, sir.
And you don't have to mention all quadrants and all. It's very difficult to see in a baby of 1 kilo, quadrants in abdomen. You just say, all abdomen moves well with respiration, right?
Okay, sir.
Right. CNS, I think CNS also cannot be, you need not do so much of detailed cranial nerve examination. Okay. Just please go back to that slide.
Cranial nerves.
Cranial nerves. Okay, so you should not say like baby is fixating on mother and all those things, because you don't expect this baby to fixate so early. Okay.
It fixates on light, sir, and intermittently on the mother's face.
That also it is very difficult to say.
Less likely.
Maybe unlikely that a baby of this much postmenstrual age would be able to fixate. Okay, so you please don't use that terminology. And then again, extraocular movements, full and free. What did you check in this? Unless the baby is following your red ring or something, you will not be able to check. So here you can say that doll's eye movement is present or not.
That's right.
Doll's eye movement was present, sir, and passively while observing the child, it was seeing not for.
But you will not expect a baby to do all these 180 degree of movement at this age. Okay. So probably you can skip all these things. Okay.
Your pupils, up to what gestation you can expect equal reaction, ma? Let's take this baby.
From 28th week of gestation, pupils will.
This baby, first week of life, if you did it, do you expect people reaction?
Sir, at that time, the child would not readily open its eyes to.
See, why sir is hesitant in saying all this is because you would be having very less time during the time of examination, right? At least for these extraocular movements, full and free, baby should be awake, active. We know there are various phases, no? Babies, active cry, feeding phase, post-feeding, activity phase, and then cry, all these steps. You can say whenever you mention about CNS examination, during the course of examination, baby was, you can mention like this, and you can tell, but for this 28 plus weeker, which you are mentioning, all these are very difficult. Even if you don't mention, it's not a big deal.
Harini, what is one landmark clinical finding which is synonymous with 26 weeks? Supposing you are not able to do a
tightly fused lids or like.
Yes. So after, if the child's eyelids are open, that means the child is more than 26 weeks. Okay. Okay, go ahead.
Next.
Fine. Okay. Again, we do not expect, all these reflexes to be examined in a growing preterm baby. We do not want you to, disturb the baby too much. Okay. So we do not expect all these reflexes. Ma'am, is that fine, ma'am? I think we don't expect in a preterm baby all these reflexes being done, right?
Yeah.
Yes.
And also, a preterm baby will not, okay, when it reaches term, we cannot expect the neurological development of that preterm to be the same as that of a term baby which is born at term. Okay. This extra uterine period for the brain will be different. So we have to have it. So we use these Hammersmith neurological examination, which will show you that for a preterm which has become term, we can give allowance for this child to be lesser in development than a term baby. So even if you don't do all these reflexes, it is fine. But if you have attempted, well and good. Just tell us what the child did and what he didn't do.
Next slide, please. Yeah. Fine. So in ventral suspension, what do you expect in this baby?
Distal actually in ventral suspension was able to lift its head momentarily in the line of the body, sir.
So what is the different from a term baby in this baby? What is different? What finding is different?
The legs are extended, sir, in ventral suspension.
So you expect
For
a
baby,
term baby will have flexed limbs. Very good. Okay, fine.
So, but we don't want to disturb like this. This 28-weeker need not be disturbed like this.
Yeah, we need not want these things to be demonstrated. Okay. Right. So your diagnosis is now?
Post-natal age of 32 days, post-menstrual age of 31 weeks, extreme preterm baby with
so you
born.
You can start like single or twin. Okay. Some of these preterms may be twin also. Okay. So you can say single girl baby or female baby, extreme preterm, born at 26 plus 4 weeks with postmenstrual age and postnatal age of so and so with birth weight this much, like that. Okay, you start like that.
Okay, sir. A single female child who was born at 26 plus 4 days gestation and weighed 910, other extreme low birth weight at birth. Currently of postmenstrual age of 32 days and postnatal age of 32 days and postmenstrual age of 31 weeks, who was born appropriate for gestational age and developed recurrent apnea, retinopathy of prematurity, of stage 3 in the right eye requiring laser therapy without clinical evidence of hearing loss or motor abnormality and tolerating enteral feeds and gaining weight.
I think you don't have to mention clinical evidence of hearing loss or motor abnormality so early, which is because you will not be able to detect anything hearing loss clinically in this small baby, and motor abnormality also is so early. I mean, you cannot identify in this baby. So instead, what you would say is you would talk about the growth of the baby, whether the baby is growing appropriately, whether extrauterine growth restriction is there or not. That is what is more important. Okay.
Yes, sir.
Okay. So what do you mean by extrauterine? Sorry, ma'am.
No, as Chandra rightly said, even if the child passes the hearing tests in the soon after birth in this child, we will definitely have to repeat the test once again when the child is 3 months old. Okay. And if the child fails or passes, we have to repeat it. We don't go by the screening test which is done at the time of discharge in preterm babies. Okay. Okay, Chandra.
Okay. Fine. So that would be the final diagnosis. Okay. You should always say that the baby is growing appropriately on full enteral feeds and growing appropriately, or there is postnatal growth restriction, or otherwise called as extrauterine growth restriction. Okay.
Yes, sir.
What do you mean by extrauterine growth restriction when you will call a baby to be EUGR? I think we have 15 minutes more, 13 minutes more.
If the weight gain of the child is inadequate and it crosses 2 centile lines or happens to fall less than 10
Yeah, so less
percentile
than 10
for the
centiles for that
for the
postnatal.
postmenstrual age.
Okay, fine. So what else you will do for this baby now in terms of management? So when you will decide to discharge this baby?
Sir, for this particular baby, I will ensure that the child takes adequate feeds and slowly try to increase the feeds. So currently, the child is 31 weeks post-menstrual age, so I will wait for a week or so and try to shift the child from OG onto full Palade feeds. And I encourage the mother to give KFC for more hours. Already she is giving for approximately 12 hours, sir. And simultaneously, I would monitor the child's weight gain and see whether the child is developing any other complications in terms of anemia or prematurity or.
So what are your targets? What are your
targets?
Sorry to interrupt. What are your targets for weight, length, and head circumference? How much this baby should gain per week?
Per week. Per day, child should gain minimum of 15 to 20 grams of weight per day, sir.
15 to 20 gram per kg per day. Okay, it's not 15 to 20 gram per day. Okay, 15 to 20 gram per kilo per day. Okay.
Okay.
Circumference of 0.5 to 0.6 centimeter per week.
That is too less.
0.5.
Any better answer? So both head circumference and length will be around 1 centimeter per week. Okay, 0.9 to 1.1 centimeter. Okay, right. Fine, go ahead. Yeah.
And monitor the child for complications of prematurity as well as to screen the child. This child is actually planned for ROP and laser correction, sir. So, and assess the development of the child and ensure immunization after it gains weight.
So immunization and development assessment and all you will do in follow-up, right? So right now, before discharging the baby in NICU, what are all the things you will do? One is feeding, you told. Okay.
Counsel the mother with regards.
One is
Counsel the mother with regard to preterm care, temperature, how to check for the hypothermia, how to maintain
so how
the
will
child.
you teach mother to check hypothermia?
Sir, I'll ask her to place her hands on the abdomen and the periphery of the child. If the child is a bit warmer than her body temperature and the abdomen and the periphery remain in the same temperature, then it will be adequate. So, and I read proper clothing of the child, right from cap.
So peripheries are cold, what she has to do?
Sir?
If peripheries are cold, what she has to do?
So she has to warm the child, continue KMC, and adequately feed the child. And if it doesn't improve, then approach a medical personnel as soon as possible.
Very good, wonderful. Okay, next. So feeding, thermoregulation. Next.
I will teach her with regard to danger signs.
Very good.
Of the child. If the child is not tolerating feeds, if the child is lethargic, or if the child is having abdominal distension, any change in the color of the child, abnormal movement, or if the child is having abnormal posture, or
Okay, very good.
vomiting,
Fine, danger signs then.
bleeding signs, bleeding
Very good, very good,
manifestations.
very good. Fine, yeah. Then
Anything else?
I advise her with regard to immunization of the child, including special vaccines which she has to
okay,
give
yes,
postnatally,
okay,
and be on regular follow-up, that is on
With
each day
handling,
that has been specified.
anything with the handling?
She has to maintain that she has to wash her hands frequently,
Stay
ensure
patient.
that there's only one attendant taking care of the child, and paladai and all other materials has to be properly sterilized before using for the child.
okay, very good. So what is the discharge criteria for this baby? When you, if you are the pediatrician who is treating this baby, when you will discharge this baby from hospital?
Or what is your units criteria for discharge? That you can say.
So after the child has reached the weight of 1.8 kilos,
1.6.
1.6, 1.8. What's your units criteria? That would be better, I think.
I think usually around 1.6 we will discharge, but if your units policy is 1.8, fine. Okay. Anything else?
and the child is continuing to gain weight persistently.
Okay.
Child is tolerating feeds adequately, that is given through either paladai or direct breast feeds, and the child should have normal perfusion and normal breathing pattern. Child should have been free of apnea for at least 1 week, and child should be off all IV medication. And mother should be confident in handling the child after ROP screening, OA screening, and the first dose of BCG vaccine. And
baby should be able to maintain temperature. Okay, that is also important. Okay.
Mother should know about the medications and all those stuff. She should be very confident.
Yes.
That persistent weight gain, 1 week is persistent for me. For sir, it is 2 weeks. Do you want to mention?
3 days of weight gain of more than 20 grams. 3 consecutive days of weight gain.
Consistent weight gain for at least 3 days. 3 consecutive days. And yours may be 1.6, but in our we follow 1.5 kg in our unit, but it's okay. 1.6 or 1.8, it's okay.
What about caffeine in this baby? This baby still on caffeine?
Sir,
Yes, currently child is
Baby is still on caffeine?
Yes, sir. Yes, sir. Child is
Okay.
still receiving oral caffeine.
Okay. So when you will stop caffeine?
After 7 days of apnea-free duration, or after child attains 34 weeks of post-menstrual age, whichever is later.
Okay, fine.
Why this baby is having Venflan, ma?
So it was planned for ROP laser correction, sir. So before sending the child, we had
in the diagnosis, we should have included RDS also, treated for respiratory distress syndrome. Okay, moderate to severe respiratory distress syndrome with surfactant replacement therapy twice. You can add in your diagnosis, respiratory distress syndrome. We have discussed about early selective surfactant therapy by sir. Sir has told, now we don't routinely use prophylactic surfactant, rather we use early selective, and now we have turned to give less invasive surfactant, right? Less invasive surfactant. Nowadays we are following to give less infection. You are supposed to know all those. See, previously ensure we are doing. Now, in a recent NRP, you would have seen.
Minimally invasive surfactant.
No. What is ensure rec? What is ensure?
Ensure intubate, surfactant, and extubate.
Now it is ensure rec. What do you mean by that?
Extubate to step.
You are supposed to recruit the lung. Okay. Ensure intubate, give surfactant, recruit, and then extubate. That is ensure rec. RE is recruitment. Okay. If at all, if you practice invasive surfactant therapy, less invasive surfactant. Nowadays.
Mr.
Yes. List, miss, whatever. Yeah. Sir, we'll finalize, sir.
Yeah. I think overall it was a wonderful presentation. Dr. Harini presented very confidently. I think her clinical examination also was very complete. So as we mentioned during the discussion, I think the neurological part and all may be curtailed so that you don't do too much of detailed examination in a growing preterm baby. In growing preterm baby, what is important is, I mean, you narrate the event which happened around birth, and then stabilization which happened in NICU, and then mainly feeding growth of the baby, whether baby is given adequate calories and protein and other micronutrients. That is what is expected. Okay, and you should know about KMC, a bit about jaundice in the baby, and then the timeline at which you will do ultrasound screening, ROP screening, and then follow-up of the baby. Okay, so overall you did a wonderful job. I think we also enjoyed listening to your presentation. Thank you.
Thank you, sir.
Sweta, please stop slide sharing. Yeah, Dr. Sendil. Yeah.
Yes, sir.
Dr. Rama, madam.
Yeah, first of all, my PG Karini, I'm so happy she did a fantastic job presenting because MD students normally it will only be a short case, but she did a very thorough presentation of the history as well as the findings, and was able to answer almost 9 out of the 10 questions that we asked you. A good job, Harini. And a little bit about the supplementation. That I don't know whether we had asked you that, but that you should know just the supplements that have to go along with the breastfeeds and all that. Okay. And follow up invariably, if they ask you that, you will have to say that all babies which are 1.5 kgs will require more frequent follow-ups in the first 3 months. So till they gain about 2.5 kg, we tell them to come once a week. Thereafter, it can be a 3-monthly follow-up. Okay. Otherwise, it was an excellent presentation. Very good discussion by my moderators, Chandra and Sendil. Thank you, and IAP, Rajendran, and the team. Thank you for this opportunity.
Dr. Srinivasan, sir. Dr. Srinivasan.
Put my comments. Excellent presentation, as mentioned by everybody, and very good discussion by all the 3 consultants. And I really enjoyed, and I feel like taking up neonatology. Those days I never wanted because so many people are not there now. So many seats are there, but age is a criterion. Okay, but anyhow, it was really very enjoyable. I enjoyed each and every second of it, and they answered so confidently, and very good work they have done. So congratulations. I think she can take up neonatology as a specialty subject.
That's very
Dr. PRC, sir. Yeah.
Thank you. First of all, the students, Harini and friends did wonderfully well, very confident, and they were to the point what was the moderators expected, they were able to answer. I should also appreciate the other 2 friends. See, even 1 or 2 questions, whenever they got a chance, they answered quite well. So that is to be appreciated. So, you know, I don't know, the கச்சேரியில தனியா ஒருத்தனை வாசிக்கிறது ஒரு 2 நிமிஷம் தான் கிடைக்கும். If you are a good artist, you will show your metal even then. Okay. So
Yes.
I really appreciate other students also who are really participating. That's very nice. Because not every time we see such a team. And regarding the faculty, I need not say anything. Dr. Rama, she's so experienced and very practical, and a lot of very clear concepts she brings to the table. So thank you, Dr. Chandra and Dr. Senthil. They're all experienced neonatologists, and it's very really very enlightening to listen to them. The only unfortunate thing is you are so well trained and you are taking care of such difficult cases, but in the exam you don't get a chance to show all this metal, because you get a case of a newborn which examiner like me, who hasn't entered a newborn ward or registration for the past 20 years, is the examiner for you, and they may not be really very good in asking even the questions to you to get the best out of you. But things should change with the emphasis on neonatology, neonatal mortality reduction, other things. There must be some way to bring out the best out of our MD students also in their knowledge of neonatology. I think it should, hopefully it will change. I have a question to Rama and Chandra Senthil. In DM neonatology, do you give them all the information like ultrasound findings, all the investigation findings, and ask them to discuss, or how do they do it?
We have ward rounds, sir, for them.
Okay.
So they have one is a ventilated patient, where of course we have to give them all the details, and the other one is growing preterm. There again we give them all the details, because we expect them to calculate the nutritional requirements, what the baby is getting and what is expected. So they have to know exactly what the baby is getting. So we give them the case sheets. Follow-up alone, I don't think we give them the entire details, which we get 45 minutes for that. So they have to get that out of the parent only. That will be their long case in the DM exam. So that we don't provide all the details. The other two, they will get the complete case sheet.
I think this concept we should also change, because in real life situation,
exactly,
you don't examine a patient without knowing all the whatever the previous investigations and the previous follow-up and diagnosis and other things. Yes. There is nothing criminal in knowing the diagnosis or knowing the investigation findings and etc., which generally the examiners do not encourage. They tell these are all the things. But I think that should change. We should really adapt to the actual real life situation. So whatever the information they are getting, they should be able to discuss logically. That's all it is expected.
Yes.
It's not that
the management.
They're not supposed to know or anything. Actually, they know that we know.
Yes.
MD, we have three cases in and the discussion time is only 45 minutes. Here now 2 hours we have discussed one particular case. That's why so much of in-depth discussion was possible.
Yes, newborn is only a short case for our PGs. So normally I keep telling them that neonatologist is not going to come for your exam. So they're going to ask you only the basic questions. And if you don't answer that, because sometimes when they ask a question like what is cold stress, they are stumped at that. They'll be able to tell you about minimally invasive surfactant therapy and the insure and all that. But these questions they may not know. So I tell them to get their basics alone, 100%. And I feel that is enough for these MDs to get through the exam comfortably, sir.
Dr. Janani Shankar, madam. Dr. Janani Shankar. Yeah, she's not there. Yeah. On behalf of IAP-TNSC, I thank today's chairperson, Dr. Rama Chandramohan. They are, as Dr. Chandrakumar said, that the answer like a DM level, they've done extremely very well, and really appreciate their case presentation to our IAP-TNSC postgraduate program. And I thank today's moderator, Dr. Chandrakumar, and as well as Dr.
Sendil Kumar, both discussed cases very well, really very well. And I think that Srinivasan are really appreciating, and he's a critical appraiser of a person, and he has really appreciated both of them and done really justice.
I learned a lot today.
Yeah. And I thank today's judges, Dr. Srinivasan sir, Dr. PRC sir, Dr. Janesh Shankar. I thank DIP person Sweda for helping us. And I thank all the postgraduate, Dr. Harini, they have done really very well. And I thank my treasurer, Dr. Gopal Subramaniam, and president, Dr. Ismail sir. Things are going very well. Thank you, one and all.